Let's now introduce Neelam Vaid, who is going to speak about funding in low and middle income countries. And Dr. Vlad is head of the cochlear implant program and Big Ears, the audiology and speech pathology department at Kim Hospital in Pune, India. Over to you, Dr. Vaid.
Thank you so much for that introduction, Ruth. And a big thank you to Sue and Sika for giving me the opportunity to talk a bit about what we've done in our country. As you all know that, India is in the middle of being a developing country and a developed world. Could I have my slides, please, Kes? Yeah, thank you so much. So what I'm going to be talking today is how we've evolved over the last 3 decades or so of cochlear implantation and how we've gone about developing our own models for funding of this, as Brian said, not, I shouldn't say the word expensive, but something that's not easily available to most of our population here. Now, India, next slide, please. India has a very big paradox. As we all know, it's a country of over 1.3 billion and growing by the second. And we have two really diametrically opposite parts of our society. We have a growing middle class now, which is economically independent and similar to almost any other person of their counterpart in the developed world. But we have a very big population which is below the poverty line. And if you look at that, we have about 1/3 of the world's poorest people living in our country. And when I say below the poverty line, I'm looking at people who are about earning less than $1.25 US per day per head. And that's what it was in 2011. And I'm sure things haven't really improved over the years that we've been in about a decade later. So the dilemma that this country really faces and has faced is that you want to give advanced technology to anyone and everyone who needs it. But you also have faced with the requirements of a developing country, which is we need to have resources to spend on our infrastructure, on our education, on other health requirements. And that's a big dilemma that this country always faces. And we as professionals, we want to give the best to the patients, but we have to realize that there are other needs that this country also needs. So one is left with the question that who's going to really provide this technology to my patient? Is it going to be the public health services, which is the government, or am I going to look at private health services that's going to provide this aid? And by and large in India, the consensus of the population is that they do still rely more on private health services. It's still used more frequently than government-aided services. So about 70% of the urban population and about 63% of the rural population would still prefer to go to a private health service vis-a-vis a government-aided program or a government-aided scheme. So now let's talk about how can we apply what's already existing in the health infrastructure in my country to cochlear implants. When we looked at the evolution in funding, right from when the CI programs in India developed, which was in the late 1990s to today, it's been an evolution whereby initially it was completely self-funded. You had the patients who had to put in the money. In the early 20s, in the first decade, there was a lot of involvement of private charitable trusts, especially here it is noteworthy mentioning the Tata Trust, which has helped numerous children across this country, and the Mahindra Trust. You had the involvement of lots of non-government organizations, especially one like SAHI, which is in Andhra Pradesh, and you got the involvement of the corporate houses. And this started coming in the first decade of this particular century. And this was all spearheaded by professionals who were working in this, who approached these trusts to help their patients. Fortunately for us, in the last decade or so, we've now seen a growing interest by the state and the central government offices, especially the health services, to now help these children who need this technology. We did realize very early on that if we had to have a successful funding program, we had to make it a point that you had these three people participating and involved in this program. And that was the professionals, most importantly, the family and the recipient, and you had to involve the cochlear implant manufacturers. One has to remember that the professionals are not going to outlive the family, but the cochlear implant manufacturer is going to be someone, hopefully, that's going to stay for them for as long as they need the help. What did we do personally when we started to look at funding was we assigned a social worker and a coordinator to assess what is the requirement of each family. One has to remember in a country like ours, and in a lot of countries over the world, what's on the paper is not what's reality. So sometimes a person may bring a paper claiming that he's below poverty line, but reality may prove otherwise. So we had to have a coordinator that actually would check on documents and see whether this person really needed that financial assistance. There was a networking that was established with individuals, corporates, charitable trusts, and this took a lot of time and patience. What we realized was the networking was helped by the fact that you would constantly send to them progress reports and case histories of how their funds helped families and helped children. And that was what gave our program that credibility that yes, if a person is donating an X amount of money for this child, that's going to the right place. Fundraising events were performed where we actually showcased our children, and it's unfortunate, but I remember talking to Sue about this and saying that sometimes we are using our own implantees and we are using them not in the appropriate way that you and I would like to, but unfortunately, that's sometimes needed to show people that, look, if you help people like this, they have a chance to do much better in life. We set up what's called a cochlear implant fund in our hospital, and this was to provide soft loans. If a family today wants to take a loan from a bank, he or she has to pay interest. What we started providing in the hospital was we would loan them an X amount and say, okay, you pay this to us over the next 2 or 3 years without interest. And by that time, we were able to push children so that we could implant them early. Because if we waited for this patient to develop and get the sources of funds, it may push this implantee a little later in life, thereby reducing the benefits. So the soft loans were helping us get into early intervention, which was the aim. We involved implantees and the families in every decision, the funding, the implant choice. We would, they would come to us with literature which would say, wow, I want the high grade or the latest implant. And we would tell them about why they should or should not go for these sort of expensive devices. We always involve the manufacturers in our decision making, especially sometimes when I had a family who was not able to really go up, make the jump. I would request them that, let's just give me a little bit of leeway so I can pay you a little later. And this worked because in India, we still have a lot of rapport, which is personal. So it's not generally that I'm talking to a company guy, I'm talking to a person, and sometimes that really helps us. As you can see over the last couple of years, and this is data from 2006 only, the amount of patients that we are doing with the help of donations far, far exceeds those that are self-paid. And this still continues right now. So where are the funds in our hospital or in India by and large coming from? About 28% is self-funded. But as you can see, the majority of funds that's coming in is still coming from the private trusts, from NGOs, from individuals, and this is still working on personal networking. What I'm happy to say here that even though the percentage coming from the government is only 7.5 plus 6.6, that's about a 15%, this has been upgoing. And when I looked at my data of just 2 years back, this percentage was less than 10%. And I'm happy to say that the government is stepping in, slow but steady. But the good thing is they are responding to our demands. So government funding in India is basically divided into the state and the central government. We have a country of 28 states and 8 union territories. And as of now, we have state funding in 12 states and 1 union territory only. So a lot of work still to be done there. The central funding comes from both there are 2 or 3 schemes. The important thing about this funding is that other than one state, all this is only for the economically challenged population. So it's not that anyone and anyone can walk in and get a cochlear implant. There's a lot of paperwork involved where you've got to prove that you really need the device, but the options now are available. This wasn't there about, I would say, a decade ago. This is just some of the papers which, we've seen now that under various schemes, you're getting more and more children implanted. We have a very, very active program in Tamil Nadu, and they've implanted a lot of children in the last 5 or 6 years. Similarly, in Delhi, as recent as March 2021, we now have cochlear implants that are going to be free of cost for the economically challenged population. The important thing I feel when you are developing a funding program or trying to develop one in your country is to not rely or put all your eggs in one basket. One has to remember that when one uses and one relies on government schemes, in a democracy like mine, governments will change, the policies will vary, officials will change. So someone who's right now giving you an X amount, next year may say, no, I'm not going to give you that much amount. So you've got to keep your options open. My only problem with this is that in all these schemes that are run by the government, the family is not a stakeholder. The choice of the implant is not made by the family. We have no way in really ensuring what is their commitment. Just the fact that someone doesn't have money does not ensure commitment. And we all know that the success or the outcomes of a cochlear implant totally depend on the commitment of the individual and the family. And that's something that I feel we need to work much more on. And we are not assessing their ability to maintain a device. The interference from bureaucracy is bound to be there. And one has to remember, today we are a group of individuals that feels very, very strongly about the hearing challenge. But there are other issues that most of our countries face. We have a big need here for malnutrition, infectious diseases like HIV. And sometimes we have to ask ourselves that when we justify to the government to put in this amount of money for cochlear implants, are we in some way denying something else that the government may at that time consider a priority? That's something that sometimes you've got to think about and put into a better perspective. The challenge that I feel with most funding programs, especially when you're relying a lot on donations, is maintenance, accessories, upgrades. This is very important. One has to realize that if we don't look at funding programs that are going to take care of these 3 major issues, you are in the future going to be looking at a lot of non-users. Fortunately for us, there are just about right now 1 or 2 states in this country that are looking at this, and especially Kerala is one state that's really looking at long-term sustainability. But I don't think that's still on paper in most of the other programs, and that's something that we are actively working on. As I said right at the outset, most of these children are going to outlive us. So we need to have programs in place that are going to look at supporting these children maybe for a 2nd or a 3rd surgery. And right now, revision surgery for any reason is not covered by these programs. So these are aspects that we need to look at to just kind of reduce the number of non-users. And I'm happy to say that the government is talking to us, and we are hoping that in the next couple of years, we should at least have them thinking positively about this. Next. So the solutions are definitely, I feel that if you're going to be looking at government funded programs, let's talk to the government, and thereby the implant is a property of the government, which means that the entire responsibility of sustaining it, of making sure that the person who's using it remains a user, is that of the government. And we've got to convince them about this. It's not just a one-off payment and that's the closure. Involvement of more and more health insurances. I think we need to talk a lot more to health insurance companies. In India, there are still some companies that do not support any anomaly which is congenital. And that's something that we need to work on. And constant dialogues with government officials. This is never ending. You've got to keep telling them the importance, and the data that Brian gave us would definitely be helpful here when we have our dialogues. I think the biggest mistake that a lot of us make is when we start out CI programs, especially in my sort of countries, which is developing, we keep waiting for others to find solutions for our problems. And I think that if you, like me, are going to be heading a CI program, you've got to push for it. A lot of the talking, the networking has to come from you, because if you're going to rely on other people to do it, it's not going to happen. And I think all of us here at SICA, we know that the driving force is within us, and that's what's going to make a success of our CI programs. To conclude, India joined into cochlear implantations very late. I think we really got into the gusto only in the last, I would say, about 10 years or so. We've done more than 50% of our implants only in the last 10 years. Today, happy to say that we are able to offer our patients everything that the developed world has. And despite several challenges, I still feel that the implantation program in India is a success story. We've got a lot of learning to do, and we've got a long way to go ahead, but we're going to do it. Thank you so much.
Thank you so much, Dr. Vaid.